Continuing along with our discussions of anatomy and physiology, with the central point of our meaning network being motions, or the central point of our semantic network being motions. So we're trying to create particular details and map them onto motion, such that motion should ideally pull these details in, or the consideration of specific motions should pull these details into our minds when we're trying to organize our understanding of anatomy and physiology. It doesn't mean that these are the perfect mappings. It just means that we're trying to create a network of these things. We're trying to bring them together so that they're easier for you to recall. Again, these are not necessarily the perfect mappings, the perfect points to overlap, but that's what we're aiming to do, is create an overlap. And also note that many of these movements have an anatomical and physiological structures and processes that overlap with one another. So we're looking at lumbar side bending and rotation here. So the vast majority of the musculature we have already gone over with respect to both lumbar flexion and lumbar extension, but we're going to note them with respect to lumbar side bending and rotation. So our main objectives here, specific discussion of what lumbar side bending and rotation are. So planes and axes, very repetitive on purpose. General discussion of the muscles that side bend and rotate the lumbar column. General discussion of the nerves that supply those muscles. General discussion of the vascular supply. So most of that's already been done. So we don't have to spend a ton of time on it because it's already been included with thoracic flexion, or sorry, rather lumbar extension and lumbar flexion. Then we're going to have a superficial discussion of the hindgut and the kidneys and the adrenal glands. And then a general discussion of areas to assess and treat should lumbar side bending and rotation issues be suspected. So just a quick rundown of planes as we do consistently here. Sagittal plane is a 50% cut of the body left to right. Horizontal or transverse plane, 50% cut of the body top to bottom. The frontal or coronal plane, 50% cut of the body back to front. So frontal or coronal, I can't remember off the top of my head if I said both terms. Then what we're looking at is axes being perpendicular to the plane. So the frontal plane, or sorry, the sagittal plane rather, has a transverse or horizontal axis. The horizontal plane has a vertical axis. The frontal plane has an AP or PA axis, or the coronal plane. So the movement that we're talking about here, lumbar side bending and rotation, is going to be both in the horizontal plane or the transverse plane for rotation, and in the frontal plane with respect to side bending. Now, a special note, the facets, particularly within the lumbar region, in most cases are going to be reported being primarily sagittal. So if you were looking straight on, rather, you'd have to look from the back, but you're looking, so there's an SP here, and you have TVPs over here. If you look at the facets within the lumbar column, they are, for the most part, primarily in the sagittal plane. However, they are not purely in the sagittal plane, and they are not the same bone to bone within each individual. There is variation. This is known. I believe if you look at netters, there is a standard, essentially common variation within the lumbar column, which is called an open facet. So you generally expect to see the facets here, but you would see one like that considered an open facet. So because we are working on the outside of the patient and we cannot see those things, we have our expectation that it's like this, but it is variable from this primarily sagittal orientation. So that said, there is going to be some degree of side bending and rotation that will occur within the lumbar column and that you believe you're going to identify, but realistically, you're still looking at torso or trunk side bending and torso or trunk rotation and its impacts within the lumbar column. So you'll notice the motion problem in the lumbar column, even if it isn't necessarily primarily in these planes, it is impacted by the trunk or torso moving in these planes. Now that said, keep in mind that although these facets are considered primarily sagittal within the lumbar column, they are variable within, so even on the same bone, the left and right, so say on L1, the inferior facet left and right may be somewhat like this. So you can expect variation in the bony anatomy to the point where motions will be asymmetrical because of bony structure. And that will highlight itself, especially when you attempt to interface with something in a predictable way and it just doesn't respond the way you would expect. So you would see this in things such as scoliosis. Now, scoliosis is having the variation between functional, so one where somebody just has a preference for motion in one direction, versus structural, where the bones are actually notably different shapes. There may be some gray area within there. Again, although the lumbar facets are primarily sagittal, there is some variation within each individual, between individuals. And really what you're looking at here is trunk side bending and trunk rotation, and then the impact that will identify itself, or the lack of motion within the grand motion of trunk or torso rotation that will be identifiable in the lumbar region. So the muscles here, again, you're really talking about the erector mass in iliocostalis, spinalis, and longissimus, as well as the intervertebral muscles, so interspinalis, intertransversalis, multifidus, and rotatories. These are all going to have some degree of play with primarily with extension, but then they're going to contribute, if they contract unilaterally, to side bending and rotation. Again, very generally, all of these muscles will side bend and rotate to the same side in most resources that you are going to read. Now, you can have disagreement with that. You may have sources that will say something different, but for the most part, the most consistent statement is that all of these muscles will side bend and rotate to the same side. Then you are going to, on the anterior side, and even on the lateral side to some degree, in the forms of the oblique musculature, as far as motion is concerned, because it primarily looks at flexion, these generate torso and trunk flexion, which will create torso and trunk, lumbar flexion. You're going to have the transverse abdominis, or not the transverse abdominis, the rectus abdominis, the external oblique and the internal oblique. Those will generate your side bending and rotation to the torso, therefore imparting it to the lumbar region. Now, the rectus abdominis and the internal oblique will side bend and rotate to the same side, whereas the external oblique is noted to side bend and rotate to opposite sides. So as with the SCM, this can become something that can confuse you, because if you're trying to look for a particular muscle, you have to start to think about things that interact in a confusing way. So every other muscle aside from the SCM or the external oblique will side bend and rotate to the same side, whereas those two muscles will stymie the process a little bit. So then you have to get really complicated to identify this, which is why I would say thinking about the motions that you find that are challenges or that are not occurring appropriately is more important than thinking about the particular muscles, because you will have this element of interactivity that is confusing. These things are confusing when you try to piece them apart, especially in the moment. So looking at the motion on its own allows you to interact more accurately with the situation at hand, as opposed to thinking specifically about the muscles. You obviously need to know the anatomy. However, thinking about it in the moment is probably going to confuse your results and your ability to act. Now, as far as the erector mass and the paravertebral musculature, very generally speaking, what you're considering here is the dorsal primary rami at the appropriate level. Then you are thinking about the intercostal nerves for the majority of the abdominal muscles. So the majority of the innervation to lumbar side bending and rotation is going to happen in varying areas. So there's going to be a degree to which thoracic side benders and rotators are going to contribute here. So as far as the erector mass, you could be considering the vast majority of the thoracolumbar region. As far as innervation is concerned, as far as the abdominal musculature, you're primarily thinking about intercostal nerves, because the rectus abdominis, and external oblique primarily get innervation from the intercostal nerves as they descend through the abdominal wall. So between the ribs, intercostal spaces, and then to the abdominal wall. The internal oblique will get some of that, but will also get some innervation from the high lumbar region. So the consideration for neural tone, as far as thinking about problems with lumbar side bending and rotation, you need to think about a very large area. Again, why I would caution you about thinking specifically about chasing a particular nerve, because its mechanical relationships will span a very large area. Whereas if you identify the problem motion, you will be more accurately able to essentially interact with the situation at hand and behave accordingly to help the patient, as opposed to chasing a nerve, which you can't necessarily see. You don't know if it's exactly that way in that particular individual because you're working from the outside. So this is why we always aim to promote looking at the motion problem more than chasing the anatomy in your brain. As far as the blood supply to the erector mass, you're talking about the lumbar arteries and lumbar veins. Lumbar arteries coming directly off of the abdominal aorta, the lumbar veins going to essentially the azygous system as it gets into the thorax, and then emptying into, I can't remember which vena cava off the top of my head, but it's going to dump into one of the vena cavas. I believe it is the inferior vena cava. I think it's around T8-ish, but my memory may be incorrect there. So that is something for accuracy that would be smart to look up. The vascular supply, as far as the abdominal contribution to the lumbar side bending and rotation, you're thinking around a large area again here. So as far as abdominal musculature, you're going to have the epigastric circulation. So coming off of the subclavian artery, internal thoracic or internal mammary, the superior epigastric artery, the iliac circulation. So the whole abdomen until it gets to the iliac circulation coming up for the inferior epigastric artery to generate the epigastric circulation. Broadly speaking, you're thinking to some degree about intercostal arteries, at least with respect to the upper portions of the external oblique, to some degree the internal oblique, and then you're also going to have some blood coming off of the lumbar veins to supply the internal obliques. So, and the transverse abdominis is probably going to get most off of the epigastric circulation. So you have a very large area to think about as far as the blood supply, again, which promotes looking at the motion as opposed to chasing the vascular supply, because then you're thinking about this whole region, then you have to make a decision as to where you would work. And the decision is easier to make when you're looking at the motion, because if there is a relationship between a mechanical dysfunction and a health and disease state, then it is usually identified with the motion itself. The relationship is figured out after, when you change the motion and the physiological process can show some degree of change, you figure it out then. What you can find is the motion problem, and you can relate it to physiological change after the fact, because it does take time. But again, thinking about all of this vasculature, you're going to confuse yourself quite easily if you're thinking about lumbar side bending and rotation and all the vasculature that contributes, because you have to think the whole torso minimum. Then we're moving into considering the hindgut. So the hindgut is what remains of the colon. So the midgut is essentially the first half of the duodenum, jejunum, ileum, cecum, the appendix, the ascending colon, the first 2/3 of the transverse colon. The hindgut is what remains, and then you're looking at the distal third of the transverse colon, the descending colon, the sigmoid colon, and then the rectum and the anus, more or less, as far as the hindgut is concerned. The hindgut is going to be supplied primarily by the inferior mesenteric artery. So you can see it in the previous picture, but you can also see it here, where essentially the inferior mesenteric artery is lower. It is, I believe, around L3, if I'm not mistaken. It's L2, L3-ish, depending on the particular subject. It is going to descend and then give off branches to the hindgut. So there is a peritoneal fold that will allow this to have orderly movement through the region to supply its associated structures. But I don't remember it off the top of my head. But you can see as it goes up, as you get into the transverse colon, so essentially the blood is going to go down and with up. But because of how this all sits, you're going to have a little bit of a circuitous path. You can see anastomosis with the arteries, with the branches off of the superior mesenteric artery within the transverse colon. So it just looks like this nice big arch. So you kind of have the left colic artery coming up. It's going to give to, or anastomose with the blood supply to the transverse colon. So you can have some redundancy in blood flow should there be a challenge to one part or the other. Again, coming off of the inferior mesenteric artery, which is the final unpaired branch off of the abdominal aorta. Now, as far as the nerve supply to the hindgut, so we're looking at a sympathetic supply and a parasympathetic supply. Because the sympathetic supply, the least splanchnic nerve, goes more or less to the kidneys, if memory serves me accurately. So you would expect that this would just continue in an orderly fashion through the thoracic region, and that the hindgut would get parasympathetic and sympathetic supply. So parasympathetic from the vagus and sympathetic from the thoracic splanchnic system. However, in this case, that's not how it goes. You have the pelvic splanchnic nerves, which are the parasympathetic outflow in and around the sacral region. And you have the sacral splanchnics, which are the sympathetic outflow around the sacrum. So what happens is those come out, those bind together to create the inferior hypogastric plexus, which is essentially inside of the sacral region. So anterior to the sacrum, you hit the sacral promontory, and then it becomes the superior hypogastric plexus. Those fibers, those nerve fibers, ascend to the inferior mesenteric ganglion. So they're preganglionic there, and then they go out they're postganglionic after the inferior mesenteric ganglia and follow the inferior mesenteric artery to supply the hindgut. So as I noted, the end point of innervation from the vagus nerve, the cranial nerve, is the distal the first 2/3 of the transverse colon, and then everything after that, all of that outflow, all of that sympathetic and parasympathetic flow in the gut tube at least is from the pelvic region, the pelvic splanchnic nerves being parasympathetic, the sacral splanchnic nerves being sympathetic. Now, if we consider the kidneys and the adrenals are going to receive mostly sympathetic tone from the least splanchnic nerve, which is going to then go down and mix with the vagus to some degree, and then that's going to go through the aortorenal ganglia and then create the renal plexus. So that's going to follow the renal arteries. Now, the renal arteries do come directly off of the abdominal aorta, essentially in the region of the celiac trunk and the superior mesenteric artery. They're just on the lateral side. And then there is a suprarenal artery, and there are suprarenal arteries, and those are coming off of the abdominal aorta in most cases, and those are for the adrenal gland. The venous system here does empty directly into the inferior vena cava. So the renal veins do go into the inferior vena cava, so they don't necessarily go to the liver first. So all of the gut, right? So the foregut, the midgut, and the hindgut go through the portal system, whereas the kidneys will go directly into the inferior vena cava. So there is a different route there because it's not necessarily but you can at least consider that both the kidneys and the livers have functions as filters. So there is filtration steps with systemic circulation that are going to occur in both, and then generate the movement back towards the heart through the venous system. However, the distinction here is that the adrenal glands and the kidneys empty directly into the inferior vena cava, where the gut empties into the liver for further filtration or further functionality that is related to the liver before going into the inferior vena cava. The least splanchnic nerve, as I noted, goes to the adrenals and the kidneys. And again, you can see how the thoracic ganglia will give off fibers that generate the greater, the least, and the lesser, the lesser and the least splanchnic nerve. And then they will descend along the aorta to the point where they're going to go along with the abdominal aorta, or the break of the thoracic aorta and the abdominal aorta at T12 through the aortic hiatus, and then they will wrap around the aorta, go to their corresponding ganglia, and then follow arteries after that to hit target organs or target structures. As far as the kidney and the adrenal glands and the hindgut function is concerned, the kidney is urine formation, osmolality, so that is essentially the more or less the amount of things that are in the blood, often with respect to electrolytes and whatnot, but that's regulation of the concentration, blood pressure regulation, hormone secretion, and acid-base balance for the body writ large. The adrenal glands are going to have some portion of fluid balance, metabolism, the androgens, right? So DHEA, sympathetic hormonal control in epinephrine and norepinephrine. So hormonal control of the sympathetic system from the adrenal glands, and that's going to go through the blood. So it tends to be slower than neural control. Now, when we're talking about metabolism, we're talking about, I believe it's glucocorticoids, the specific names, which aren't right in my head at the moment because I didn't write them down here. And so those two glands, well, really those two structures, the kidney and the adrenal gland, are closely related to one another. All of their functionality will go back. So everything that they're getting fed by, that they're monitoring, is going to come through the arteries. Everything that all of the processes or the end results of their processes go into the venous system, so into the renal veins, inferior vena cava, eventually hit the heart, and then be pumped out. So their functionality is primarily through the blood. The distal third of the transverse colon onwards, so the hindgut, essentially what you're looking at is whatever remaining water or micronutrients are there, it will absorb and leftover. So yeah, some absorption of water because there's not much leftover micronutrients, and then essentially movement of leftover chyme. So once everything's out of the chyme, it's considered fecal matter. So it's movement of the fecal matter down to the rectum and the anus. So for excretory purposes. Areas of consideration for assessment and treatment. So this would be basically a blending of all of the areas you would consider for both thoracic flexion and thoracic extension. So you're considering the erector mass, the lumbar vertebrae themselves, the abdominal wall, T-spine generally, the ribs and the hips, all as has been explained through related, especially muscular anatomy, but soft tissue and connective tissue anatomy. Now, the things that would keep you away from this region or cause you consideration or cause you reason to consider being careful or not treating in the region, known or suspected fractures or tears, including tears of the annulus fibrosus, which were usually termed bulging discs if it is the internal layers of the annulus that have torn, and a herniation if it is all of the layers of the annulus has torn to allow the nucleus pulposus to pop out or to push out and start to come in contact with the vertebral ligaments. Known or suspected fractures or tears of especially the abdominal wall here, possibly some of the hip muscles. You're not likely to get a tear in the erector mass, but you may very well have lumbar fractures of varying kinds or pelvic fractures, and those would usually be associated with recent trauma. Rebound tenderness of the abdominal wall, you push on the abdominal wall, nothing hurts, you let go and then it hurts. That is a serious visceral pathology. Until proven otherwise, you refer that out. Known or suspected abdominal aortic aneurysms, as noted, an abdominal aortic aneurysm is much easier to identify superficially than a thoracic one because the thoracic wall won't bound in relation to an aneurysm within the thoracic region. But with respect to the abdominal region, with lean patients, you do expect to see some bound of the wall even when normal, especially when they are not, when respiration isn't actively occurring. So even if it's gentle breathing, when the abdominal wall has stopped and paused for a moment, you will often see some bound in lean people. But in lean people, if it's a possible abdominal aortic aneurysm, it is a very large, pronounced bound. And if you have somebody who is not as lean, you can still see that bound when there's a possible abdominal aortic aneurysm. If you suspect that for any reason, you refer out before any form of treatment, because treatment has at least the possibility of passively creating pressure through that weakened aortic wall or abdominal aortic wall at the site of the aneurysm, and you want to be extremely careful with that.